Hello, my name is Sebastian Schmid. I am a urologist and working at the Department of Urology of the Technical University of Munich in Germany. So the RAISE-IT study is a trial about patients with locally advanced bladder cancer. Locally advanced bladder cancer is a situation where you have patients with a very poor prognosis. So, for example, if you have stage T3, T4, then usually, despite the radical therapy, after 5 years, only 40 to 50% of patients are alive. And if you have patients with positive lymph nodes, then this rate drops to a survival of 20 to 30% after 5 years. So these patients have a really poor prognosis. And neoadjuvant chemotherapy didn't change that so much. Recent publications have shown that neoadjuvant cisplatin-based chemotherapy leads to response rates, to complete response rates of only 15 to 20%. Furthermore, a significant part of these patients is cisplatin ineligible, for example, because of renal insufficiency, and this goes up to 50%. So there is a real need for better therapies to get a better outcome for this patient group. So one of these things to think about is obviously the use of the checkpoint inhibitors, which have shown their activity, for example, in the metastatic setting. And one especially interesting combination is the combination of checkpoint inhibitors with radiation therapy. And this is because of the fact that this combination is believed to have synergistic effects. Radiation therapy leads to the induction of immunogenic cell death, and so to improved antigen presentation to T cells and also to cytokine release, leading to immune stimulation, which is massively aided by the checkpoint inhibitors' effect on the T cells. On the other hand, radiation also has immunosuppressive effects, which can be counteracted by the checkpoint blockade. So it is believed that these might lead to synergistic effects, as I said. So this was the rationale for our trial. So in our trial, we included patients with locally advanced urothelial bladder cancer. So they had either a T3, T4 stage or had pelvic lymph node metastasis up to the aortic bifurcation. And these patients either had to be unfit for neoadjuvant cisplatin-based chemotherapy or be refusing chemotherapy. And we treated this patient with a combination of radiation and immunotherapy. The treatment started with the immunotherapy with the infusion of nivolumab for 4 cycles every 2 weeks, and after 1 week, a radiotherapy was started with a total of 50.4 gray to the bladder and 45 gray to the pelvis. And after that, we performed a standardized lymphadenectomy and cystectomy. We saw promising results. We included a total of 33 patients, and in these 33 patients, we saw a complete response, so PT0 in the pathologic specimen in 38.7% of these patients, and downstaging to PT1 or less occurred in 58.1% of these patients. Also, the radiological overall response rate was around 70%, so we have quite promising results there. Still, we saw that around 20% of these patients had lymph node metastasis at the final pathology. Disease-free survival rate at 12 months was 90.6%, and the study reached its primary endpoint which was a combination endpoint checking on the feasibility of the study with the rate of patients who completed the treatment of nivolumab and radiation therapy and cystectomy in time until week 15. And here, 87.1% of patients reached this endpoint. So we don't have the results of this analysis yet, so I cannot answer this question now. But when we will publish these results, we will be able to answer these questions. So our trial was a phase 2 study. So in the end, it's an exploratory study. I think what our study shows is that the radioimmunotherapy as a neoadjuvant therapy in locally advanced bladder cancer before radical cystectomy is feasible and safe. This is what it shows. And for the efficacy, I would say it's definitely promising, but obviously to really know which combination is better, is, for example, the radioimmunotherapy better, or is it a combination immunotherapy or whatever, we would need head-to-head phase 3 trials. Currently, we have the situation that the data which is there on neoadjuvant immunotherapy in bladder cancer is not directly comparable, because most of these trials don't look at locally advanced bladder cancers as we do, because in our trial, virtually all patients were locally advanced and a third of the patients had lymph node metastasis, whereas in the other trials, the rate of locally advanced or lymph node metastasized patients was much lower or not there, so you cannot do direct comparisons so far.